Peripheral nerve localization is about using clinical patterns to identify where the lesion is and what type of nerve pathology is present. In this video, we will focus on recognizing peripheral nerve disease after the nerve root and before the neuromuscular junction. We will look at motor, sensory, and autonomic features, then use the pattern of involvement to distinguish axonal from demyelinating neuropathies, mononeuropathies, and root lesions. This approach helps guide investigations and management. A peripheral nerve lesion occurs after the nerve root and before the neuromuscular junction. Peripheral nerves carry motor, sensory, and sometimes autonomic fibers. This means patients can present with weakness, sensory symptoms, pain, reduced reflexes, or autonomic dysfunction. The key clinical clues of peripheral nerve disease are lower motor neuron weakness, sensory disturbance, neuropathic pain, reduced or absent reflexes, and sometimes distal muscle wasting. The pattern may be symmetrical, focal, multifocal, or length-dependent. Peripheral neuropathies can affect motor, sensory, autonomic, or mixed fibers. Motor involvement causes weakness. Sensory involvement causes numbness, paresthesia, pain, or sensory ataxia. Autonomic involvement can affect sweating, blood pressure, bladder, and bowel function. There are different pathologies that can affect the peripheral nerve. These include axonal, demyelinating, radiculopathy, or mononeuropathy. The pattern of involvement helps us to differentiate them. We will go through these in this video. Once you suspect a peripheral nerve problem, the next major distinction is whether the process is axonal or demyelinating. After that, look at the distribution. Is it a symmetrical, length-dependent neuropathy? If that is the case, then it is likely axonal. If there is involvement of cranial nerves, respiratory involvement, hips and shoulders more affected than ankles and hands, then this could be demyelinating. Axonal neuropathies often present with a distal, length-dependent pattern. The longest nerves are affected first, so symptoms commonly begin in the toes and feet, then progress upward. The hands are affected later, producing a stocking glove pattern. Common causes of axonal neuropathy include diabetes, alcohol use, renal failure, vitamin B12 deficiency, toxins, medications, and inherited neuropathies. The tempo is important. A chronic length-dependent neuropathy suggests a different cause from an acute, rapidly progressive neuropathy. Demyelinating neuropathies affect the myelin sheath, so nerve conduction becomes slow or blocked. Clinically, weakness can be prominent. Reflexes are often reduced early, and both proximal and distal muscles may be involved. Important demyelinating causes include Guillain-Barré syndrome, chronic inflammatory demyelinating polyradiculoneuropathy, paraprotein-associated neuropathy, inherited demyelinating neuropathies, and some toxic causes. Guillain-Barré syndrome is especially important because it can progress rapidly and affect breathing. Mononeuropathy affects one named peripheral nerve. The clinical pattern should match that nerve's motor and sensory distribution. This is often due to compression, trauma, entrapment, or focal ischemia. Recognizing named nerve patterns is clinically useful. Median neuropathy commonly causes hand sensory symptoms and thenar weakness. Ulnar neuropathy affects ulnar hand sensation and intrinsic hand muscles. Radial neuropathy may cause wrist drop. Common perineal neuropathy can cause foot drop with sensory loss over the dorsum of the foot. A radiculopathy is a nerve root lesion. It often causes neck or back pain radiating into a limb, with sensory symptoms in a dermatome, weakness in a myotome, and reduced reflexes if that root contributes to the reflex. Sensory nerve conduction studies may be normal because the lesion is proximal to the dorsal root ganglion. Investigation starts with localization from the history and examination. Blood tests look for reversible causes such as diabetes, renal disease, vitamin deficiency, thyroid disease, infection, inflammation, paraproteins, or toxins. Nerve conduction studies and EMG help classify the neuropathy. MRI is useful if a root, plexus, or cord lesion is suspected, and CSF may be needed when inflammatory neuropathy is suspected. The key to nerve localization is pattern recognition. First, identify whether the symptoms are motor, sensory, autonomic, or mixed. Then decide whether the neuropathy is likely axonal or demyelinating. If it does not fit into these types, then consider mononeuropathy or root disease, and confirm the pattern with appropriate investigations. Thank you for listening to this video. Good luck with your future neurology patients with a nerve localization.